Good morning. My name is Virginia Schobel, and I'm the neurology franchise head here at Spherix Global Insights. I am pleased today to have Dr. Patricia Coyle here on the line with me. Dr. Coyle is a well-known MS specialist who is the director of the MS Comprehensive Care Center and professor of neurology at Stony Brook University Neurosciences Institute. Thank you, Dr. Coyle, for joining me today.
It's a pleasure to be here.
That's wonderful. Thank you. Well, as you know, we've been working really closely together over the last couple years. You're one of our MS advisory board members, and we've been seeing here at Spherix trends over the past 4 years from our physician-reported and patient chart review data that has shown that neurologists have recently, probably within about the past 2 years, become much more comfortable using Ocrevus for their relapsing remitting MS patients, that their first-line RRMS use of the brand has increased, and that their satisfaction with Ocrevus outcomes has improved for these patients. Interestingly, though, in comparison, perceptions and treatment patterns for Ocrevus in primary progressive MS have remained really quite stable since launch. And in primary progressive MS, really the brand dominates primarily due to its unique label. Does this align with your experience in the clinic?
Absolutely. And what it indicates is that ocrelizumab has been on the market now for several years with no really negative safety signal seen. And thus the confidence in using it has been growing. I think it's a very interesting issue. Neurologists don't tend to be the first ones to do anything. They tend to be a little bit conservative. And I think also neurologists and MS neurologists in particular have been burned by natalizumab. That was back in the early 2000s where this was expected to be a dominant disease-modifying therapy, came on the market, and then had to be temporarily pulled because progressive multifocal leukoencephalopathy had reared its ugly head. And then it came back on the market, but with a restrictive safety program. So I think people got a little bit burned on that. And it just kind of reinforced that when a new agent comes to market, and remember, when ocrelizumab came to market, there were questions about breast cancer. There were questions about cancer. But the longer it's on the market and looks good, et cetera, then there's confidence in using it. I think the discrepancy between relapsing and primary progressive MS is really pretty simple. The data is just not that great in primary progressive MS. Remember the concerns about age. They capped it at age 55. Does it really work in older progressive patients? To be honest, we are not certain. We don't have the data. The post hoc analysis that indicated females with primary progressive MS didn't have a progression benefit. They've not really addressed that yet. And you don't expect no worsening. You're going to continue to progress. The best you have is to slow it down. So I think that really confounds how people feel about ocrelizumab for relapsing MS versus ocrelizumab for progressive MS.
That's really interesting. And I remember the abstract and poster that we did really digging into treatment patterns with ocrelizumab among female versus male and younger versus older patients, really supporting that in the clinic. Physicians are using the brand differently. What would you think the potential impact of the recently approved 2.5-hour infusion time might have, if any, on uptake and use of the brand?
I think anything that shortens and simplifies the time in a chair in an infusion room would be viewed as beneficial, as positive, because it allows you to move more patients in. You don't want to keep patients there any longer than you have to using the chair. So I would view that as a positive feature. Certainly, we've instituted it. Interestingly enough, there are some patients who don't want to do that. Okay. So we do, in shared decision making, we do discuss it with patients. And if the patient says, no, I really don't like that, I want status quo, I want to keep it, then we will follow that. We would not make them do the shorter infusion, but it certainly makes a lot of sense.
For that patient, is it more about comfort with the longer term data and clinical experience with the 3.5-hour infusion?
I don't really think it even gets down to that. It's the concept broadly of if it's not broken, don't try to fix it. They don't want to tamper with success. Now, it's kind of silly, but that's how they feel.
Interesting. So I'm sure you saw the news last night. The subcutaneous formulation of Biogen's Tysabri received a complete response letter, a CRL. If Biogen ends up being successful and be able to bring the subcutaneous formulation of Tysabri to the market, do you think that would change the competitive dynamic between Ocrevus and Tysabri at all?
You know, I wonder if that might actually backfire a little bit. To be honest, the patients that we have on natalizumab, there's a certain camaraderie in coming to the infusion room. They're coming on a regular basis. They have their own little clique, their own little group. There's a socialization aspect to that patients find extremely positive. And you lose that if you're going to go to, sub-Q, at least sub-Q, using it at home. So it will be interesting to see how much of an impact that actually makes.
It's really interesting. What about the potential impact of an approved higher dose for Oberves? I know that's currently in clinical development by Genentech Roche. Any thoughts on that and whether it would make a difference for one subtype more than the other?
So there was preliminary data suggesting that clinical efficacy data, disability data might be influenced by the size of the patient and the dosing. If you can present data that you can get an improved control of the MS damage process by giving higher doses to certain individuals, then that would be viewed, I think, as a very positive issue. You'd have to have confident data, but I believe that's what they're trying to document. And I think if you could really show proof of that, I think people would embrace it, obviously.
Do you think that could maybe change the outcomes and the breadth of the positive outcomes in primary progressive MS? Do you think that could potentially have been kind of an underlying factor with older patients and females?
Show me the data. Show me the data. I'll buy it if I see the data. Otherwise, it's speculative. Show me the data.
Absolutely. Totally agree. So obviously, the last year has been an interesting one with the COVID pandemic. And yet we've still seen multiple new launches of disease-modifying therapies in the MS market. So when you think about some of these new market entrants, how do you see these new therapies impacting Ocrevus, if at all? Let's start with Zeposia, a next-generation S1P receptor modulator. Do you see any dynamics between Ocrevus and Zeposia, or even more recently, Ponvory, the fourth to market S1P receptor modulator?
So you're really talking about oral ozanimod and oral ponesimod, second generation S1P receptor modulators. They're completely different kettle of fish. Okay. So just think about how you group the MS disease modifying therapies. I group them as needle injectables, orals, and the high efficacy monoclonals. So really the oral S1P receptor modulators, I don't see them as major competitors for the high efficacy monoclonals where I would put the anti-CD20s. I think the S1P receptor modulators are, first of all, competitive within their own class. So which S1P receptor would you choose for an individual patient? And then particularly competitive among the orals. Mm-hmm. With regard to the anti-CD20 ocrelizumab, the real competition there are the other anti-CD20s. And we have one, ofatumumab, and we have a second waiting in the wings, mm-hmm. ublituximab.
Yeah, exactly. With subcutaneous Kesimpta, and then we have Ublit in the wings. How do you foresee that dynamic potentially evolving over time? Ubla is going to launch onto the market potentially with a shorter infusion time, but now we do have the 2.5 hour infusion time for Ocrevus. And is there also then any aspect with rituximab, the Rituxan and the biosimilars of rituximab that plays into that dynamic?
So this is a very interesting field. Rituximab and the biosimilars are never going to be FDA approved for MS. I know that we have pockets in the country where it's actually the preferred drug for MS, strictly on a financial basis, okay? So I don't see that penetrating widely because it will never be FDA approved for MS. Not that it's bad, but there's some preliminary data suggesting it may make individuals more vulnerable to a poorer outcome with COVID-19 than the ocrelizumab. It's a chimeric with more mouse immunoglobulin, et cetera. Okay, so that will remain there, but I don't see it really taking over the market here. With regard to ocrelizumab versus ofatumumab, right now you really can't hang your hat with clear evidence-based data of superiority of one over the other. To me, I'm presenting them as really similar to identical efficacy, but conceptually, one involves getting a dose twice a year coming to an infusion room. The other is a lower dose based on a more regular basis every 4 weeks that you can take at home. So which is your preference? Would you prefer to do it in the convenience of your home, or would you prefer to come to an infusion center twice a year and then not think about it? Now, if we get some data that says, for example, ofatumumab has less impact on vaccination,
right,
and that becomes a big deal for COVID-19 vaccines, or you get and ultimately less likely to get hypogammaglobulinemia as a long-term benefit, or you're less vulnerable to infections, you need some objective data to pick up other things to indicate a superiority. Why you might choose one versus the other. The ublituximab is interesting because it's really an every 6-month infusion. So it's directly going up against ocrelizumab in that point of view. We find that most patients prefer the less frequent administration, that they find that more comfortable and they don't mind coming to an infusion room twice a year. So ublituximab may be quite competitive for ocrelizumab, and then it may come down to pricing, okay?
Right.
And that may be a very key feature. So if you have a 1-hour infusion that's highly efficacious, much cheaper than your other option, I could really see it gobbling up some of that market.
Yeah, and to go a little off script, but when you do bring up price, I think that's really interesting because with Bristol Myers Squibb's ozanimod, Zeposia, I really thought there was an opportunity there for them to come in at a different price because of the fact they also have that clinical development program in IBD, which is a lower priced indication compared to MS. And so I was a little surprised when they came in at such a high price, just in terms of their future plans.
Yeah, I think we're going to become more and more aware of pricing of drugs, and there has to be a break. You can't have generics coming to the market and everybody raising their prices. This is just not going to last. And we heard very interesting discussions from President Biden about trying to target getting better control of pharmaceutical pricing. I think this is coming. It has to be coming.
Mm-hmm. No, I agree. Just a few more questions. So shifting our attention to primary progressive MS, obviously there's a huge unmet need for more than one approved therapy for that type of MS. Are there any agents in the late stage pipeline that you think could be a real competitor to Ocrevus for primary progressive MS?
So the data for oromasitinib is interesting. This is an oral tyrosine kinase inhibitor that had a phase 2/3 trial. It did 2 different dosing, 300 patients in each study versus placebo. And the lower dose, 4.5 milligram per kilogram daily by mouth, was successful in what they believe they tried to enter non-active progressing MS, both primary progressive and secondary progressive, and they got a statistically significant benefit in less progression on EDSS compared to oral placebo. Now, this is appealing because it's an oral agent. It appears to be very well tolerated. It does hit innate immunity, mast cells, microglia, and macrophages. And they really said this is not active. This is not a focal inflammatory relapsing component akin to what one might argue for ocrelizumab in primary progressive MS, and what they said was so for siponimod in secondary progressive MS. So we'll see. There's a larger a study planned, and I think you definitely would need to have confidence. But right now, I would say to me, masitinib looks the most interesting for progressive MS, the furthest along.
I also feel like with the BTK inhibitors, which seems to be the next new mechanism of action that may be entering the market, I find the different development programs for Genentech's fenebrutinib versus Sanofi's tolebrutinib interesting, because Genentech's actually using Ocrevus as an active control in primary progressive MS versus Sanofi's using the placebo. Any thoughts on that?
So I think that's probably the most interesting current trial to look at. Takes a lot of guts. So they're going head to head in primary progressive MS with patients randomized to ocrelizumab versus oral fenebrutinib, as you pointed out, a BTK inhibitor. That's a gutsy trial, head to head. So actually, if you were to ask me what's the most interesting current trial, that would be it, to see what happens there. That'll be very, very interesting. If by any chance fenebrutinib beats ocrelizumab, you've just evaporated the ocrelizumab primary progressive MS market. It's like gone.
Right, because we saw in our data with the special topics report that I shared with you, we saw in our data that really the primary driver of the selection of Ocrevus for primary progressive MS is its approval for that indication. And we did actually, in our most recent survey, ask what would be the impact of non-inferiority against Ocrevus or fenebrutinib, and the majority of physicians, of course, said, yes, that would decrease my use of Ocrevus. Where if, but then if you asked if it was found to be superior to Ocrevus, yeah, it absolutely will change the treatment patterns in primary progressive MS.
Right, right. And as you're saying, even if it's shown to be equivalent an oral agent, and particularly if it didn't have some of the baggage, yes, it would be used.
Well, just one last question. Obviously, we had another virtual AAN conference this year, just last week. What did you find to be the most intriguing MS-related data at the conference that you heard?
I would mention 3 studies. So the first was the report of Ultimate 1 and 2. I was very surprised that wasn't an oral presentation. So this is the major phase 3 trial of ublituximab, a 3rd generation glycoengineered chimeric anti-CD20, where patients in 2 relapsing trials that were identical, Ultimate 1 and 2, were randomized to the anti-CD20, 450 milligrams every 6 months, or oral teriflunomide. And you had very strong data on suppression of relapses and suppression of MRI disease activity, very high NIDA data in the range of 44.6%, 43% versus 11.4%. They combined it for confirmed disability worsening, and that was not statistically significant, but you had a very low proportion of each aim. So I think that's the most important clinical trial that was reported. There was another little report from Belfast, Northern Ireland, that was very telling about the institution of a neuroimaging review of MRI scans in MS. And it was pretty shocking, but I can tell you that this is what we find too. In 40 to 42% of the cases, the reading of the MRIs were changed. Many of them were not being read by neuroradiologists, and there were errors, there were mistakes. So the reports got changed. People that were said to be active weren't active. You had 4% where the diagnosis of MS was being questioned. It really says the value of making sure You have neuroradiologic expertise that's reviewing the MRI scans. The third study that I would just mention came from NYU, and it was really looking at MS individuals on disease-modifying therapies, anti-CD20, in this case, ocrelizumab versus others, and the response to COVID, both antibody-based and cell-based. And so they made a response greater than 9 months out, although the antibody response was attenuated with ocrelizumab, anti-CD20, the antibody titers were lower. The cell-mediated response looked very good. And they actually have a study now where they're beginning to look at COVID-19 vaccine responses with the various MS DMTs. So that's going to be very important.
Very important. Absolutely. Well, thank you so much for that perspective on the MS market this morning, Dr. Coyle. As always, it's been a pleasure speaking with you today, and we look forward to continuing to track the evolution of the MS treatment with you. Well, have a wonderful rest of your week.
Thank you so much.